Yes. Good morning, everyone. I hope you can hear me. It's my distinct pleasure to introduce our Grand Rounds presenter today, my very well-admired colleague, Tom Kovesi. For those of you who don't know Tom, which is probably exactly one person joining online today at most, he's a pediatric respirologist. Sorry, I have my phone on, it's distracting me. Professor of Pediatrics at the University of Ottawa. He completed his residency training at CHEO at the Isaac Walton Killam Children's Hospital in Halifax. His fellowship at Sick Kids in Toronto. Dr. Kovesi has been on staff at CHEO since 1992. His work has included the development of Canadian National Asthma Guidelines, description of the respiratory complications of congenital tracheoesophageal fistula, and research on the effects of problems with indoor air quality on the respiratory health of Indigenous children, including Inuit children and First Nations children living on reserves in Canada. This is his primary research focus, and his research group has published the most comprehensive descriptions of indoor air quality in houses in Nunavut and First Nations Reserve in Northern Ontario that are available, as well as one of the largest RCTs on modifying indoor air quality in the world. Dr. Kovesi has served as chair of the Ontario Thoracic Society, chair of the Pediatric Assembly of the Canadian Thoracic Society, Chief Examiner for Pediatric Respirology, Royal College of Physicians and Surgeons of Canada, and Anglophone content expert in respirology. Unit 1, Faculty of Medicine, University of Ottawa. He's a member of the Executive International Network on Esophageal Atresia. So a very short list of accomplishments for Dr. Kovesi. The thing that I'd like to add that's not on Tom's bio is that from my perspective, amongst many researchers that I know, and I know lots of them, he tends to choose research questions that are super practical, super translatable to bedside care almost immediately. And today's talk is no exception. So with that, I will pass it on to my esteemed colleague, Dr. Tom Kovesi.
So thank you very much, Dr. Radhakrishnan, for that very kind introduction. I'll be doing the land acknowledgement this morning. I don't like traditional land acknowledgements because they're rote and I think they lose their power. So I'm going to give one that I learned from a Cree comedian, and it runs like this. I want you to imagine that as Dr. Radhakrishnan was giving that very kind introduction, I was rummaging through her purse and I find her wallet. Um, and I steal her wallet. And I acknowledge that I've stolen her wallet. And I acknowledge that I ain't never giving it back. That's a traditional wallet acknowledgement. Now, Dr. Radhakrishnan's job is to reconcile her fact with the fact that I have stolen her wallet and reconcile herself to the fact that I ain't never giving it back. That's truth and reconciliation. Shimmy wedge. So let me get this running here. All right, so I'm going to start off with two kind of hypothetical cases. So Helena is a 9-year-old girl with asthma. She's got a 2-day history of a cold, wheezing and trouble breathing. She's treated like most people in our region with PRN, Ventolin, or salbutamol, and fluticasone. She presents to the emergency department, and her parents tell you that they measured her O2 sats at home with their fingertip oximeter. They bought it on Amazon for $25, and her sats were 85%, and they were really worried. In Emerge, her PRAM score is 5, her sats are 94. She gets the usual treatments, her PRAM goes down to 2. Emerge is ready to send her home, and the parents tell you that they're really worried. Her sats were 85 at home, and they want to get some more treatment before she leaves. And so, how do you feel about this? What are you going to do about it? And I'll warn you, for both of my cases, usually when you give cases in rounds, you give an answer at the end. And I'm not going to give you any answers. I want you to kind of think about how you feel about these things. So the second case is Maverick. Maverick is a 2-day-old baby born at 37 weeks. Billy meets the threshold for phototherapy and he gets admitted on a Wednesday. As per routine, he's put on a continuous SAT monitor, continuous electronic monitoring. That evening, the nurses note he has DSATs. The team orders an overnight oximetry on Thursday in room air, and its reported as showing an immature pattern of breathing consistent with periodic breathing, about 12 desaturations less than 90 per hour, SATs below 90 for 7% of the night. By Friday morning, his billy is in the normal range. Oops. And on Friday, respirology is consulted, and they recommend a repeat overnight oximetry and put 125 liters of oxygen. It's fine, it's much better. The medical gas companies in Ottawa are closed on the weekends, so oxygen gets ordered for Monday. And basically, he goes home on Monday, sees respirology a month later, repeated oximetry in room air, it's fine. He comes off his oxygen and he's fine thereafter. So Maverick has now been in hospital for about 5 days for a 2-day problem. And the question really becomes, could this have been prevented? So the objectives this morning are to understand the accuracy and limitations of consumer-grade oximeters, recognize what portion of your patients have a SAT monitor at home, how people use it, and then in preparation for the viral season, we'll talk a bit about the use of oximeters in the hospital. In terms of declarations of conflicts of interest, I don't have any personally, but these are all consumer devices. They all have commercial names, and I will be using commercial names throughout this presentation. And my bias is that I think oximeters are overused in hospitals, and we'll talk more about that shortly. So let's start by talking about some basic principles. So all of you are familiar with the oxyhemoglobin dissociation curve. And the things to keep in mind is this curve always reminded me of my favorite ski hill at Edelweiss, which is Zoomer. And Zoomer starts off kind of boring and flat at the top. And that's similar to oxyhemoglobin dissociation curve. Basically, once your PO2 is more than about 70, which corresponds to an O2 saturation of about 90%, whether your PO2 is 70 or 370, your hemoglobin is almost fully saturated with oxygen. The PO2 really doesn't matter very much. Once you hit that magic number of 90, after that time, the ski slope gets really exciting. It gets very steep. And so with a small change in your PO2, your O2 saturation, and therefore your blood oxygen carrying capacity drops very quickly. Uh, Pulse oximeters like this one all have an error range of about plus or minus 2%. So if you are aiming for an O2 sat of 92, there's a 95% chance your actual saturation is at least 90. And that's where that magic 92% comes that you see in all the orders at CHEO. Now, in terms of oximeters, the big problem with this is we see saturations as a binary proposition. So in other words, if your SAT is 93, it's great. If your SAT is 89, you get put on oxygen. And that's different from almost any other test in medicine. If your normal hemoglobin is 120 and your hemoglobin is 117, nobody cares. No one is going to give you a transfusion for hemoglobin 117. Whereas with oxygen, there's this cutoff where either it really matters or it doesn't matter at all. So one of the obvious questions is, I think I missed a slide here, is how do saturation monitors actually work? And the way they work, all of you are familiar with the little probe. It's got a red light on one side, it's got a sensor on the other side. You stick it on your thumb, and what comes out are two wavelengths of light, a wavelength of red light and an infrared near red light wavelength of light. And all of you remember from kindergarten, if you shine a red light through a red liquid, red light comes out. And if you shine red light through a bluish liquid, which is kind of what the oxygen hemoglobin looks like, purple light comes out. And so at a very basic level, think about the more the red light changes color, the more your saturation has dropped. One of the tricky things about pulse oximeters is my thumb has lots of things in it other than blood. it's got bone marrow, it's got my fingernail, and you don't want this machine to measure all that stuff. So the machine's smart enough to know that every time my heart beats, it sends a gush of arterial blood into my thumb. It looks at the change in the density of my thumb, and that's when it does its measurement. So the little bar graph that you're all familiar with is really measuring the changes in density of your thumb. And that's why when you have an accurate oxygen saturation, you also have an accurate heart rate, because that's what the machine is reading off. So one of the obvious questions is, does this cool little yellow machine actually do all that stuff? And the answer is no. The way oximeters work is when you want to invent a new oximeter, you go to somewhere where you can find student volunteers. Usually this is done in Japan. And you take about 10 people, you insert an art line, you put them in a hypoxic chamber, keep dropping the FiO2 in the chamber, and you measure what happens to the numbers that this machine reads, and you come out with a data table. So you look at the ratio of the density that comes out at the two different red wavelengths, and you record that. And then in a machine like this, instead of measuring all these cool things, it has a little data table built into its memory chip. And it says, okay, if my ratio is this, according to the table that we came up with in our lab, your O2 saturation is that. So it's really just measuring a table rather than anything else. One of the tricky things is that most of these things are done in Japan. So they're people with relatively light skin. And these things are done in very carefully controlled conditions, where people are not moving, they've got an art line, very different from a wiggly 2-year-old up on the floor. And the protocol that the FDA uses to approve devices is exactly the same as what I just described, at least assuming the people at the FDA haven't been fired yet. So these things are very cool. You can use them in the hospital all the time. What's out there online? And what's out there online looks pretty much like this. So if you go on eBay, I found more than 14,000 different pulse oximeters available. Most of them cost, well, they were about $20 before the tariffs, and now closer to $30. Similarly, if I go on Google Shopping or Walmart or Amazon, there are thousands and thousands of pulse oximeters out there. And the obvious first question is, how good are they? So let's start by talking about how we study that. So one thing to keep in mind is the type of oximeter methodology I've been talking about is called transmittance pulse oximetry. So a red light goes through my thumb, it comes out the other end, and a sensor measures stuff. A lot of new oximeters use what's called a reflectance pulse oximeter. So basically, red light gets shined into my thumb. The light changes its color based on the color of the blood in my thumb. It bounces back out to the same side, and a sensor measures it. And we'll come back to that. So smartphones, watches, rings, all use that technology. So there's a few definitions we have to think about. Bias is how much above or below the true value the reading is. Correlation, all of you are familiar with. And there's this complicated term called the average root mean square, or ARMS. And basically, it looks at the difference between each measurement that you do and the real value. And it kind of ends up being something similar to standard deviation. And the FDA requires an ARMS of less than 3% with an O2 saturation range between 70 and 100%. So when somebody's O2 sat is 50%, that's based on a guess. That's not measured by the companies, and it's not required by the FDA. You only need 10 people to certify a pulse oximeter, and they specify that only 2 of them have to have dark skin. Another method of looking at this is called a Bland-Altman plot. And these are really, really useful because it shows how different each value is from the real value at a range of O2 saturations. We'll come back to that shortly. So of the research which has been out there, it's really very limited. If you think about those thousands and thousands of oximeters available online, only a tiny fraction have actually been studied by anybody. And where studies have been done, it's pretty hard to find people who are desaturated, believe it or not. At least it's like any research. As soon as you want to look for something, they disappear. So most of these studies have been done in people with SATs are 90% or higher. Um, Very few of these studies are done comparing your oximeter to an actual arterial blood gas. Most of them are done comparing a hospital oximeter with your study oximeter. Few of these studies have been done in kids. Few of these studies have been done in dark skin values. And of course, every study reports something different. So we did a study published in Respiratory Care. Jeremy Saban was a pediatric resident who's now a pediatrician in Gatineau. And John Haddad is I think, finishing his residency now in Calgary. And basically what we did was we took a group of cheap pulse oximeters and compared them with a hospital oximeter. And so the hospital oximeter we used mostly was this fellow, an Elcor N65. And the three cheaper oximeters we used was a Samsung Galaxy S9. I guess I should do it here so people can see this on the screen also. This little adult pulse oximeter, and this very cute little device, which was marketed as a pediatric oximeter, and it looks kind of like an owl. It's very cute. And the probes for this oximeter are designed for people 30 kilos and older. So we looked at these oximeters with big people, 30 kilos and older, and small people, people who were less than 30 kilograms. So these are our three devices. One was by a company called MCP Healthcare. One was by a company called Concord Emerald. And of course, Samsung is made by Samsung. So what did we find? We looked at 74 children. About 54 were small, with an average age of about 2 years. And the rest, of course, were bigger. We tried to get people with cyanotic congenital heart disease, so we'd get more people who were actually desaturated. So the first thing that we found was our Nellcor, our hospital oximeter, got a successful reading in pretty much everybody. The cheap adult oximeter worked well in terms of getting readings in bigger people. The cheap pediatric one, close. The Samsung had a lot of trouble. It only got successful readings in about 60% of people. In terms of how long it took to get a reading, the Nellcor did it in about 30 seconds. The cheap pediatric one took much longer, about 100 seconds. The cheap adult one was quick, it was about 20 seconds. And the Samsung took ages. It took up to 3 minutes to get a successful reading. So if we look at these devices one by one, in terms of the cheap pediatric oximeter, the bias was minus almost 5%. So the values that it was reading were significantly lower than the patient's real values. Its ARMS by FDA standards was pretty terrible. It was about 8%. And you can see on the bland Alpin plot that it was fairly accurate when your SATs were more than about 90. But when it was less than 90, the values were really all over the place. They were much less than the real values. For the cheap adult oximeter, it looks really good. Its values are very close to what you expected. The ARMS was 2.5%, but we couldn't find big people with low SATs. So it was a real limitation of our study. We didn't really measure this in the kind of people where you'd really like to know the results. For the Samsung Galaxy, once again, for people with bigger people with relatively normal SATs, it functioned reasonably well. Though the limits of agreement still varied between about minus 13% and 7%. Um, the ARMS was sort of okay if you were a big person, more than 30 kilos, and it was not adequate if you were less than 30 kilos. So in terms of the limitations of our study, remember we only studied three cheap oximeters out of the thousands and thousands available. Compared to other studies, we had a reasonably good sample size. Uh, I had originally planned that we would use only that oximeter as a reference oximeter. Um, the learners I had recruited to the study didn't quite understand that, and they used a couple of oximeters there as a reference, so not perfect. Obviously, we used a reference oximeter. We didn't do arterial blood gases in all these people. We didn't have that many people with low SATs. We didn't quantify skin color, which some of the best studies do. And we didn't quantify motion, how much these kids were moving around. Um, and for little kids, we of course use the Band-Aid probe that all of you are used to, and that's not really a fair comparison because for a squirmy little 2-year-old, a Band-Aid probe is going to get more accurate readings than any of these fingertip devices will. So, in terms of what it all boils down to, is first of all, pulse oximeters have more trouble with little kids because their fingers are smaller. There's less blood in there, there's less signal to work with. And that's going to be true of any pulse oximeter. In addition, kids move around, and oximeters have trouble with that. If you're moving around a lot and you're measuring someone's O2 sat with any device, you have venous blood, which is moving, sloshing around. And these machines look for blood which is sloshing around. They don't care whether it's arterial blood or venous blood. So if you're sloshing around appropriately, the machine will start measuring your venous O2 sat, which is extremely cool but useless. But that's why these machines often measure falsely low rather than falsely high. The bottom line was the cheap adult oximeter worked pretty well for people with relatively normal sats who are pretty big. The cheap pediatric oximeter worked kind of so-so and didn't work at all in babies. And it had a significant failure rate. Once again, having a smartphone oximeter worked reasonably well in older people who weren't moving very much and where it took a long time to get your measurement. It worked terribly in little kids and especially in babies. And one of the things that's hard is when you look at machines which have such a large error range. As a healthcare professional or as a parent, what do you care about? Do you care about the actual number, whether it's 93 or 95.6, or do you care about a threshold? Do you want to know if it's above 90 or below 90? And when the error range is so big, it can be hard to tell. So there are a number of other device studies out there. There's been a couple looking at fingertip oximeters like the ones that we used. And again, they all had worse performance, more bias when saturations are really low, which is when you really care about the pulse oximeter. And again, their ability to confirm whether your sat was normal or not was relatively low because of these wide error ranges. There's also a bunch of studies looking at smartphones, both older generation iPhones and the Samsungs. The iPhones did not work very well, and in all likelihood, the iPhone that one of you has can't measure O2 sats. Apple is in a patent dispute with Masimo, which makes a lot of oximeters. So the current, I don't know about the new iPhone 17s, but the other recent ones can't measure O2 sats. For Samsung, it's interesting. Some of the Samsungs have a dedicated chip and light, which was built specifically for measuring O2 sats, and which was designed with the same kind of studies that are used for FDA-approved devices. And those work well in adults, but that's really the only population where it was looked at. In terms of smart watches, the older generations worked really quite terribly. Some of the newer smart watches vary a lot in terms of their accuracy. And then finally, the newest thing is called a wearable ring, which is a thing called an EV ring, and it's a very cool device because if you think about it, if it's a ring oximeter, the sensor and the light are always going to be exactly opposite each other. And this device actually meets FDA criteria with an ARMS of only 2.1%. So now that we've got some sense of the limitations of pulse oximeters, what do our patients actually do with this? And so we did a second study again with, um, sorry, I've got the wrong title up there. It was done with a med student at the time. And we did a cross-sectional study of 200 patients in 3 different clinics, the respirology clinic, the cardiology clinic, and the GI clinic. And we basically asked people, do they have a pulse oximeter? And if so, what did they do with it? And we really divided patients into 3 groups. People who had bought a pulse oximeter, people who had one prescribed because they're on a home oxygen program or with home BiPAP programs. So they had a government issued pulse oximeter, and people who didn't have a pulse oximeter. And overall, about half of our patients came from the respirology clinic, about a third came from the cardiology clinic, and 16% from the GI clinic. And the average age of these kids was about 8 years of age. And only about 6% self-reported Black ancestry. So in terms of the population, 74% of these people did not have a pulse oximeter. About a quarter of them did have a pulse oximeter. Of the people who had a pulse oximeter, 81% bought them, 19% had one prescribed by a healthcare professional. And of the people who bought them, 84% had a fingertip oximeter, 2% had a smartwatch, and 2% had a smartphone. In terms of where the people bought them, who bought them, about half of them bought them online. 30% bought them at a pharmacy. I didn't realize how easy it is to buy these things at pharmacies, but they're common. 5% said it came with their smartphone or smartwatch anyways. 3% bought them at a medical supply center, and 13% borrowed their oximeter from somebody else. So in terms of what portion of our patients have one of these things, 50% of the people in the sleep and the home ventilation clinic had one, not surprisingly. 35% of people in the respirology clinic had an oximeter. 22% had it in the cardiology clinic. Of the patients with asthma, again, a third of them had a pulse oximeter at home. And in the GI clinic, where I didn't think anybody was going to have a pulse oximeter, 13% of people had a pulse oximeter. And the difference between these different clinics was actually not quite statistically significant. I think in a slightly bigger sample size, we would have found that. So when did they use their oximeters? 84% used it when the child was sick. That kind of makes sense. 11% used it every day or every night. 2% used it to monitor for chronic aspiration or as an apnea monitor. 6% bought one but never used it. About a third of patients who had one had its use discussed with a healthcare professional, and about a third of them had brought their oximeter to an appointment and actually compared their oximeter with the readings with a hospital-grade device. Another thing which we kind of asked is, what do people consider saturations to be? So the green bars is what they felt a normal saturation is supposed to be. So most people felt a normal sat so between about 95 and 98%. So that's good. That's pretty close to what it really should be. In terms of what people thought their usual saturation, people reported the usual sats vary. That's the blue bar between about 90 and 100%. In terms of the saturation that made people worry, by far and away the commonest value was 90%, which fits exactly with our guidelines. That was great. And in terms of the saturation that would make people worry and decide to bring their kid to emerge, there was huge variation. Again, the commonest number, that's the red bar, was 90%, but there were people who would worry when their SATs were 70. Those are presumably cardiac kids. But there are also people who would bring their kids to emerge if their O2 SAT was 95 or 96%. So 18% of people worried when the child's SATs were 95% or higher. One parent said that if they were worried about the SATs, they would check the instruction manual. Two would check Google, I guess. One parent said I would use the symptoms and not the SAT monitor. And the mean O2 saturation that would make people go to emerge was 88%. And it was significantly lower in the cardiology patients, presumably more of those patients had cyanotic congenital heart disease, where they expected the normal SATs to be lower anyways. Interestingly, 37% of these people visited the emergency department because of their child's O2 SAT. So you can realize just how much of an educational opportunity there is dealing with these devices. We asked people how accurate are the device. 70% felt it was very accurate. 30% felt it was somewhat accurate. Nobody felt it was less than that. So once again, we have this subgroup of patients who actually got a pulse oximeter prescribed by a healthcare professional and delivered through the Ministry of Health. And for those people, 40% used it every night, 30% used it every day, and 30% used it only when they were worried. Once again, they consider normal SAT to be 96, the range between about 93 and 100. They felt the average for their child was about 94. they'd be worried if it was 88, and they would go to emerge if it was 85% or less. And all of these people had been taught by a healthcare professional how to use the device sitting in their house. So if you put all this together, uh, overall at CHEO, based on the data that we have, about a fifth of children who come here have an oximeter at home. And that's true of nearly a third of respirology patients. Bear in mind that 20% of our population worries when their child's O2 sat is 95 or higher, and 14% didn't know what a normal O2 sat was. The average value that would prompt people to go to emerge was 90%, which fits with most pediatric guidelines. One of the questions that we didn't ask, and I wish we had, was do people worry about given values, 90% like the golden number, or do people vary when the child's O2 sat changes by 3% or 5% or some other percent? We didn't ask that. But either way, there's problems because these machines all have a significant error range compared to what it's supposed to be. But either way, there's overlap, and especially when the child's sick, their perfusion is less. These things will become less and less accurate in sicker and sicker children. Pardon? And finally, we need to bear in mind that as our emergency room gets busy, O2 saturation monitors drive emerge visits. 37% of our patients had actually gone to emerge because of an O2 sat. In terms of limitations, we had a big sample size, but I wish we had a bigger sample size. We didn't validate our questionnaire. Um, Again, we didn't look at thresholds. We should have asked parents what's the range that their O2 sat was normal. We didn't do that. We didn't have precise medical diagnoses. And maybe the GI clinic are a more medicalized population than the average kid living in Alta Vista in Ottawa. Maybe these people worry more, and maybe that number is artificially high. We don't know. Race was self-reported. Um, and again, we didn't ask the healthcare professionals whether they had a target O2 range that they cared about, O2 sat range. So there's only one other study that's ever looked at people who have pulse oximeters at home. And this was a study looking at 30 adults with COPD in Australia. And in this population, most of whom bought their own pulse oximeters. And the bottom line was they used their pulse oximeters to adjust their own O2 treatments at home. So based on these devices of variable accuracy, they would dial up the flow rate on their low flow or dial it down based on the numbers that came out of these machines. So I think there's room for more research, and if there's an interested resident, I think there's the opportunity for another study here. And I think the questions we need to ask is first, what makes people decide to buy an oximeter? What range of O2 sats do people consider normal? Do families typically make decisions based on a given value, that threshold value, or based on a trend? And how much trust do healthcare professionals put in the numbers which are reported by families? In other words, if somebody comes into emerge with a SAT of 85 reported at home, how much do you worry about that? How much do you believe it? And that's true both in emerge and I think also in our clinics. So, in terms of the conclusions from this study, I think you should bear in mind that up to a third of your patients have a pulse oximeter. These things all have a significant error range, meaning that using these machines is a bit problematic. Based on our data, if someone's O2 sat is normal, it's not, they say it's 96, it's likely normal. However, if it's lower than that, the number really could be anything. It's worth keeping in mind that this is an ever-changing landscape. The devices available on Amazon, I'm sure, change every couple of months. Even when it's the same device, they probably get upgraded and whatever. Nobody really knows what's really happening out there. People ask me, based on all of these studies out there, if you've got a family who are very wealthy, who really want to buy an oximeter and want to buy the best, or maybe they've got really good insurance, what should they buy? And my answer is really a couple of devices, but these are all true only for larger children or really adult-sized children. And so my answers would be the Samsung Galaxy S9 or later, or the Galaxy Smartwatch 4 or later. Those use that special chip, which is actually been tested at least to FDA standards, even if it's not FDA approved. The EV ring and the Lucky O2 ring, which are those ring devices, um, and the known and true O2 and Onyx Vantage are both FDA approved oximeters, which you can buy online without a prescription. And these things all cost about $600. So I think what these studies are telling us is that asking if a family has a pulse oximeter at home needs to become part of our respirology history. We should be asking this routinely. If they have a device, we should be educating them about how to use the thing properly, how to interpret the display, what the limitations of the technology are, and to look at the display in the context of how the child looks as well. So look at it in terms of the clinical picture. Um, we should encourage people to bring the devices to appointments and to emerge so they can compare their devices with hospital grade devices. And there are a couple of decent websites available to help educate families on proper use of these home devices. So if we go back to our case, this is the 9-year-old girl with asthma whose SATs at home with a fingertip device was 85%. And how should you interpret that? I'll let all of you decide, based on all this data, what you think you should do with that number. And with that, I want to change channels. Obviously, it's September, it's CHEO, respiratory viral season is around the corner. There will be lots of people coming here, and they're all going to get their O2 sats measured. So, a couple basic principles of the pulse oximeters. Number one is pulse oximeters lie. If you have motion artifact, you will not get an accurate reading. So first of all, always ignore the O2 sat if the child is coughing, crying, pooping, eating, vomiting. There will always be motion artifact. It really doesn't matter whether the O2 sat is 85 or 25. The number doesn't mean anything. If the display doesn't fit with your clinical impression, make sure the probe is on properly. Sometimes we reuse those Band-Aid probes for weeks and they get dirty and grungy and they're not accurate. Get a new probe put on. Make sure that the light emitter and the sensor are exactly opposite each other. Um, and I think one of the important things is the longer you apply a pulse oximeter, the more time it's going to spend lying. So pulse oximeters work beautifully in the OR when you've got a child who's anesthetized, who's not moving. If you have a critically ill child, again, they probably don't move very much and it's going to be accurate. Once that child is getting better and they're busy and they're moving around in their bed, the machine will be less and less accurate. And the best way to get rid of desaturations is stop measuring the O2 sat, which in other words means changing the order from being in a continuous oximeter to getting O2 sats Q2 or Q4 or whatever it is. And part of when you're examining a patient, you're going to be shocked if you look how many kids who look absolutely fine are still attached to a continuous oximeter. And when you see that, simply change the order so the SATs are measured Q4 or whatever, and it's going to help solve the problem. Now, another thing to keep in mind is during COVID, a lot of data become much more evident that oximeters lie even more if you've got dark skin. And this became a huge issue in New York City the early days of COVID when you got admitted to hospital if your O2 sats were low. And what studies really found, there's a bunch of studies out there, is most of the devices overestimate O2 sats in Black people, typically by around 3 to 5%. Which means that if you were Black and you walked into the hospital and your O2 sat was 91, everyone said, great, go home. But your sat actually could have been 87 and you should have been admitted. So we need to bear that in mind, that these numbers are a little bit artificially high in people who are Black. And another crucial thing to keep in mind is a lot of people who have sickle cell anemia also happen to be Black. And sickle hemoglobin has a different affinity for oxygen when it's polymerized. So it's got normal affinity when you're not hypoxic, but it's got abnormal affinity when you are hypoxic. And in this case, you may again have a falsely high reading. Your sats may be lower than you think it is. So another piece to keep in mind as bronchiolitis season heads up towards us is there's been a couple of studies looking at how people deal with O2 sats for babies with bronchiolitis. And first thing to keep in mind, there's been a couple of surveys that people are more likely to give oxygen if the sats are more than 92% rather than 94%. Emerge doctors are more likely to admit when the sats are a little bit low. Um, but in one study in San Francisco, a quarter of patients were stayed in hospital longer because they were given oxygen longer because of their oximetry results. So once again, that really comes back to the concept that when you've got a baby with bronchiolitis that's getting better, turn off the continuous pulse oximeter. Um, in another study, again, if you aim for somewhat lower target, you got fewer saturation alarms, and you're likely to get discharged more rapidly. There's been a couple of studies, one interesting one in 4 United States hospitals, where they randomized patients to either continuous oximetry or intermittent oximetry. And the patients with intermittent oximetry, if their SATs were low, then they got on a spot check. Then they got 5 minutes of continuous oximetry, unless their SATs were really below 80, in which case they got put on oxygen. And disappointingly, in that study, the length of stay was actually not significantly different for the people on continuous or intermittent pulse oximetry. Another study which was actually done in 6 hospitals in Ontario, including at CHEO by Catherine Pound, again, randomizing patients to continuous, what the heck? Oh, wait. Or intermittent oximetry. Again, they found that O2 tended to be used less oxygen. O2s tend to be used less often with intermittent oximetry, but the differences were not statistically significant. So even though I really believe that intermittent oximetry gets kids home faster, the data doesn't quite support that yet. So let's go back to case number two. So case number two, as you recall, is Maverick, the 2-day-old admitted with jaundice, who spent nearly a week in hospital because of low SATs, um, had been put on a continuous oximeter when he arrived, even though he didn't have any respiratory issues. I think all of you can kind of guess what's the best way to have shortened his length of stay. So the final piece that we'll talk about is you've got a child up on the ward with bronchiolitis. They look fine. You want to send them home. They've been on continuous oximetry despite today's grand rounds. In the morning, you come into the rounds, and the nurses say, well, the child had a couple of DSATs last night, so we put the patient back on oxygen. And you really don't know if they were real DSATs. Was it a motion artifact? It's hard to tell. Um, that's when you start to think about an overnight oximetry. And in my eyes, there's a couple indications for overnight oximetry. The first is to, in this situation, to see whether the DSATs were real, are they significant, how often are they, how bad are they? That's one indication. A second indication is for prescribing home oxygen. And for prescribing home oxygen in Ontario, the government's guidelines are really weird. So in Ontario, the criteria for home oxygen are based on COPD patients. And there's a famous study from the 80s called the KNOT study, where they found if your O2 sat was less than 88 for more than a third of the night, you're more likely to get pulmonary hypertension. And in 2025, the government still uses the same criteria. If your sats are less than 88 for a third of the night, you get oxygen. None of us are happy with that. So basically, um, we use our own criteria. It often needs letters from us to the Ministry of Health justifying why we want to give oxygen for a baby who's having lots of DSATs. But either way, you have to quantify this. either with an overnight oximetry, or if a child's really got low O2 sats, let's say a child with chronic lung disease, a 5-minute strip chart showing 2 minutes of desaturation will also make you qualify. The third indication for an overnight oximetry is to assess the adequacy of oxygen therapy. So you're on 0.125 of oxygen. You're really not sure if that's enough for that child. Do an oximetry and see if you need more or less. And finally, it's sort of an economically deprived person's sleep study. Um, and bear in mind, the oximetry, as the next slide will show, really only shows two things. You've got a recording of oxygen saturation over time and heart rate over time. So first of all, if you see a DSAT, um, we can't tell you whether it's a central apnea or a sleep or obstructive apnea. They all look the same. And certainly if you're doing an overnight oximetry, the most useful thing to do is either have a house staff spend a little time by the bedside or ask the nurses, when the child desats, what is the child doing? And often if you just sort of take off the bed cover a little bit, look at the child. If they're desatting and they're absolutely not breathing, you know it's a central apnea. If they're obstructing like mad and they're desatting, you know it's an obstructive apnea. But this machine will not give you that information. The next key thing to keep in mind is that with these devices, the one that we're using, if this motion artifact and poor signal quality usually gives us this, the line changes from green to red, and we can discount that, but it doesn't always work. So if you see a DSAT, it's possible that it's real, and it's possible the machine is lying. So there's limitations to this technology. So at the end of the day, bear in mind once again that these machines won't tell you why someone desats. Having a bedside log, so you know that at 2 in the morning the baby was fussy and mom picked up this baby and was rocking the baby around, and that's why the SATs are going all over the place. That's useful information for us. Bear in mind that when we read these studies, deciding whether DSAT is real or artifact is purely subjective, and at least a lot of the time. And you can give the same oximetry to Dr. Katz or Dr. Radhakrishnan or I, and you'll probably get slightly different answers in terms of interpretation. Um, Also keep in mind that if you have obstructive sleep apnea, you can obstruct and not desat. On the alternative end of things, you could have obstructive sleep apnea, and your DSAT could be because of motion artifact and not because of your apneas. So the sensitivity and specificity of these machines for determining sleep disorder breathing is relatively limited. Another huge issue is there are no set criteria for how to read an overnight oximetry. And you can go to 15 different pediatric hospitals, and you'll probably have at least 10 different ways of how people read these results. A number of centers use an eyeballogram. You look at the sheet of paper and say, well, it looks pretty abnormal to me. Um, and that's all the people do. At CHEO, I guess I started this, but I felt we should try and quantify this as much as possible because that way we can look at response to therapies. So you have a child with Pierre-Robert sequence, they have 36 DSATs per hour, we put in a nasal trumpet, we do it again, and they have 14 DSATs per hour. That's useful information, I think, for the ENT teams or the pediatric teams, which is why we quantify these things. But the bottom line is when you order one of these things, on average, it takes us about 20 minutes to read one. And on the other hand, since the government knows that a lot of people just eyeball these things, the amount of remuneration you get on the OHIP fee schedule for those 20 minutes is $13. So they're not a really economically viable way of generating revenues, but it is what it is. So, to me, what are the rules for overnight oximetry? The first one is do the study when the patient is clinically stable. Giving me an oximetry to read and I'm going to spend 20 minutes for my $13. When you say, well, the child's in the middle of having a severe rhinovirus infection, we were pretty sure it was going to be bad. is frustrating. It's a waste of time and money. It's not going to give us any information. If you have a child who's having multiple interventions, they have severe hypoglycemia and they need a blood sugar measured every 2 hours. Remember that an overnight oximetry is supposed to be kind of like a poor person's sleep study. And if you're waking up every 2 hours for a blood test, you don't sleep and you have solid motion artifact. So again, you need a child who's stable, who's not needing interventions all through the night. Um, when we read an oximetry, given that these things take a while, if you're on two different FiO2s, to give us meaningful results, we have to measure all of these values both on one FiO2 and then on the second FiO2. And we're willing to do it for two FiO2s. If you're titrating oxygen, so we get a report saying this child was on 0.03 liters of oxygen for an hour, and then 1.25 hour for an hour, and then 0.25 for another 2 hours, and then back to 0.125 for an hour. And we're supposed to interpret all four different periods separately. It would take the patience of a saint. Us are that saintly. So never ever do an oximetry to titrate oxygen. What we want you to do is kind of make a guess what you think is the right FiO2 for that patient, do your oximetry, and then we can tell you if it's the right FiO2 or not. Never order a daytime oximetry. Um, Babies are all more awake during the daytime. You get more motion artifact, and you can't interpret the result. And similarly, if you order a 24-hour oximetry, which A, takes forever to read, and B, is full of motion artifact, we will be thinking unkind thoughts about you. Do not do that. And finally, if the study is not working out, you start the study and that night the child comes down with paraflu, or the child's whatever, got a UTI and is up all night being irritable. Just cancel the study and order it for another night. Having us spend 20 minutes to read a study that's uninterpretable, again, is a waste of time. We also really depend on the bedside nursing and RT staff to keep an eye on these devices to make sure the machine is attached properly, it's reading correctly. Doing a study where after an hour the thing falls off, again, is frustrating. So when I when I was a third year Peds resident at CHEO, that's when CHEO got our first two pulse oximeters. And they were this model, they were Nalcor N100s. And they both came in a little cart with wheels. And we thought it was the best thing since the Sony Walkman. So up until then, to look at gas exchange on a pediatric patient, you either have to do an art gas, and none of us like doing art gases, or at night the residents would do cap gases. And despite being a pediatric respirologist now, I was always terrible at cap gases. They always had air bubbles, they never worked. And then these two devices arrived, and you would order the RT to roll the device over to 4 East and measure an O2 stat on your patient, or sometimes we actually took the machine ourselves and we rolled it over to 4 West and we got our measurement. And we thought this was like the best thing ever. There's no pricks involved. And we lobbied the hospital to get more of these devices. Sometimes you really have to be careful what you wish for. So to conclude, remember that always ignore the O2 stat when a child is crying, eating, pooping, etc. Stop continuous oximetry for patients who don't need it. Stop continuous oximetry for patients who are recovering, stable, and active. Follow the oximeter rules for ordering these things for overnight oximetries. Make sure the patient's stable. Make sure they're able to sleep that night. And don't use more than 2 FiO2s. And also, please make sure you don't send the wrong order in. It's not unusual that we get an overnight oximetry and someone forgets that they've ordered it, so they ordered the same thing for the next night. These things do take us time to read, and reading one that's completely unnecessary is poor use of our time. So I think with that, I will conclude and open things up to questions. Yeah.
There's some people who would maybe do their own oximeter. we have data on the outcome? Like, was there treatment needed, admission needed, or data?
It's another study waiting to be done. It's an excellent question. Dr. Katz.
Thanks for an excellent talk, Todd. I wholeheartedly agree with everything you said. One of the things that often is a source of frustration is that the patients sometimes seem to look like they're quite well on the board on oximeters, and then people order an overnight oximetry and then are surprised to find how many desaturations the patient actually has. And it becomes frustrating for the teams treating, for us, very bad news, and for the families. And I think there's an important technological difference between the ward oximeters and the ones at home. And I wonder if you want to comment.
Sure. So the first question had been, is there outcome data based on families using oximeters at home? And we don't, it's a great question, we don't have an answer. And then Dr. Katz's comment is that often people are frustrated that we see many more DSATs on our oximetry studies than you see on the bedside oximeters. And that's partly intentional. Studies have shown that all of us ignore alarms on electronic devices. And studies have shown that pulse oximeters will pick up DSATs that no one notices, even in critical care units like NICUs and PICUs. And certainly from an NICU point of view, one of our bits of advice is our worst case scenarios is child's um, has BPD, came off oxygen a week ago, they're supposed to be discharged tomorrow, and the night before someone orders an overnight oximetry, and we will find lots more DSATs than NICU had been aware of. So then we order another oximetry, we start oxygen, and everyone wants to throw a shoe at us. So in that kind of scenario, get the oximetry a week before you think they're going home so we can get things done ahead of time and not delay discharge. But the reality is first that these devices will pick up more DSATs than you will pick up at the bedside. And secondly, the devices are also set slightly differently. And Dr. Ursu is an expert on this, that depending on how long a DSAT you have before the machine alarms will also determine how many alarms you have. And in fact, Dr. Ursu just published a study, Dr. Katz, last month's journal reviews, where they looked at oximetries in healthy babies. And oximetries in healthy babies are like feeding studies in healthy babies. Um, Babies don't breathe very much in the first month of life, and they feed terribly. And if you do studies, they'll be very abnormal. And very rapidly, over the first couple of months, babies really get the hang of breathing. They really get the hang of swallowing, and things become much more normal.
There is one question on the chat, but I wanted to ask you something. I wanted to ask you a question first. You said something about when you checked on eBay, there were like 14,000 oximeters listed.
Mm-hmm.
But what's eBay?
Oh, that's low.
Okay. Dr. Barisiak has a question about if you are asking patients and families if they have a home oximeter, will that then motivate them to get one, that they think they need one?
It's a good question. I think oftentimes they will ask that question, and then you give them the answer. And by and large, I discourage people from getting home pulse oximeters because the error range is just so high. Again, it becomes a tool. I mean, occasionally for a patient with asthma who are really poor perceivers, just like peak flow monitoring, which is not a terribly good device, occasionally it's better than nothing. And there you can have that discussion and be very clear about the limitations of this technology. Any other questions?
I think that's it. All right. Well, thank you again, Dr. Kovesi, very much. Extra talk, very informative.
I guess we'll put more into the words.